of this webinar came in really recently when I was discussing with Dr. Manal about the rise of COVID cases, death among a pregnant lady. And then we shared this idea that we should really touch on this subject. So I was talking to my friend, Dr. Philip Barkley, who was our senior obstetrician, and I mentioned that idea to him of starting this webinar. And Philip, as a great man he is, he said immediately yes. And he said, even if you ask me to come to Iraq with you, I will do that. I said to her, no, we're not going to Iraq, we're just going to have a webinar. So here we are. It's going to be two UK presenters, speakers, and I would present them personally when we come to that, and then we're going to have two local Iraqi consultants as well. And then at the end of the webinar, we have two presentations of two important cases of COVID, which ended up in death among pregnant ladies. And then after that presentation happened, we open the discussion for the panel, for everybody. The most important bit is to let our expert panel to look at the management and to give their comments, whether good or critical comments, that doesn't matter. Everything is fully confidential. There are no names mentioned here, and everything is going to go by the book. So right now I'm going to start with our first speaker, Dr. Philip Barkley. Dr. Philip Barkley is a type of anesthetist. You like him to be with you in theater when things go wrong, because he inspired that confidence and coolness. And he just need to look at you to understand what you need from him. And he have very interesting biography. I'm going to read you some of some things. He started being a consultant in 1999. In fact, that's the day when I came to UK and I was just a poor junior doctor. So he was consultant from that time. So imagine how many years of experience he has. And then he progressed throughout the years. He came to West Middlesex in 2014, and he's been a senior obstetric anesthetist there since. He took part in, let me just read you some of the things I have here. He has a long-standing interest in high-risk obstetrics and has authored a chapter on Oxford textbook of obstetric anesthesia in maternal critical care. He's a member of several NICE guideline committees and has co-authored NICE guidelines on intrapartum care for women with existing medical condition or obstetric complication and their babies. And then obviously on hypertension in pregnancy, diagnosis and management, and then cesarean birth. So all these, his senior work, which he spent over these years in doing these guidelines. So he would like to share some of his experience with us. He's going to talk about important subject here is obstetric anesthesia, not in any time, just in this critical pandemic time. Philip, I leave the platform to you, darling.
Thank you very much for a lovely introduction. I'm going to, let's have a look. I'm going to share my desktop now. Hopefully this is going to work. Okay, so hopefully you've got Ali, have you got a good view of my first slide?
Absolutely, absolutely.
Fantastic. So yes, I've been at West Middlesex for a few years now, and a lovely time working with Professor Nakash. It's a great pleasure to be invited to speak at the seminar about how this has affected obstetric anaesthesia. And obviously, what I'm not going to do is what some of my colleagues have done in the past. I'm not going to steal Dora's presentation. It's such a temptation when you think, oh, the ICU stuff, that's so exciting. But no, the ICU stuff is Dora's. I'm going to talk about how this affects the provision of obstetric anaesthesia. But so what I'm going to do, I'm going to talk about what happened to the obstetric anaesthesia service since at the time of COVID, what was happening before COVID? What we learned during COVID, how we dealt with it during COVID, what have we learned since then, and how's this going to affect our practice in the future? That's really what I focused on here. So just to introduce you to West Middlesex University Hospital, I'm not sure Professor Nakash has done this in his previous talks, but the hospital where I now work, it's a medium-sized hospital that serves the west of London. If you want to know where it is, basically, if you fly into London and you look out just before the plane lands, it will be down there. It's literally on the flight path into London, into London's Heathrow Airport, so biggest airport in London. And because of that area where, because it's so close to the airport, then there's people from all over the world live there. I mean, there's an incredibly diverse local community, 120 plus languages spoken in the local area. The hospital itself was opened in 1920. In fact, we've just celebrated its 100th centenary. And as you can see at the top picture, the main hospital was modernized in 2003 at great expense. So that looks nice and pretty. The part where Professor Nakash and I work, though, is actually still the original maternity unit. That actually dates back to 1932, and that's called Queen Mary because she was the queen at that time. But it's fairly busy. It's actually gone up to 5,000 deliveries a year, thereabouts. And they keep telling us that in 5 years' time, we're going to have a lovely new maternity unit. But they've been saying that for a few years. Who knows? I might give a seminar talk to you in a few years' time, and they'll still say in 5 years' time we're going to get a maternity unit. So when I think of how we're dealing with COVID, we really had like a sneak peek of this with the swine flu H1N1 pandemic. Now, I'm not sure what effect that had in Iraq, and that should be interesting to hear from you what happened. But we certainly in 2009, I mean, you know, by COVID terms, I mean, this is so small, isn't it? I mean, we're talking single, let's say what, 80, it says peak of what, say 90,000 people at peak. And the number of deaths was literally in the dozens. But nevertheless, our virologists, our epidemiologists have said this is an important pandemic. You need to prepare for this. And in fact, what happened here was that Australia was ahead of the curve. So that it seemed to affect Australia first of all. And then it seemed to sweep into the UK. And what happened was that basically for most people, it was actually just a touch of seasonal flu. In fact, my wife actually had a bit of swine flu. It just laid you low like any other flu would do. And of course, the problem with flus is that, as you know, that the flu vaccine has to be reconfigured each year to try and match which likely strains are coming up. And this wasn't covered by the flu vaccine that had been given previously. So this pandemic comes along, but the reason why it's so interesting for this audience is because pregnant women were particularly vulnerable to swine flu, 4 times more likely to be admitted to hospital than the general population, 7 times more likely to be admitted to ITU. And this is a case that I personally dealt with. This is back in Liverpool. So this, as you can see from the previous slide, this is the second wave in October. So from the first wave, we've had some information from Australia saying, really, if pregnant women get this, be aggressive, intubate early, intubate the moment they develop respiratory failure, and if you can consider ECMO. So that was available, information was available. We'd had a few months to get that information to us. So October 2009, this young woman presented, and basically her family had developed this flu-like illness, and she just became pyrexial, and then we took some gases and type 1 respiratory failure. You can see the effect on her chest X-ray, and so we needed to deliver her, send her to ITU, and then transfer her to literally halfway across the country to Leicester, because that was one of the few units that actually had an ECMO service, and she needed 4 weeks of ECMO. And I think she needed to have some lung resection at one point, and took her literally 12 months to make a full recovery from this. But that was a very clear lesson into how the challenge of dealing with with viral illnesses. Now, we gave some antivirals, but it, Relenza, but it didn't have any effect on the time course of her infection. So we've got some lessons. So the lessons are, if you can, get people vaccinated. That was a really strong finding because there were a number of pregnant women that actually died. So that was the lesson to pregnant women: make sure you're vaccinated. Use personal protective equipment when dealing with aerosol-borne diseases, and then maybe antiviral medication, although the actual contribution it makes is sort of so-so really. So then what I'd found was that after that, we then would have each year, we would then have a number of patients who had come to delivery suite with influenza. And in fact, I had a case at West Middlesex shortly after I joined, which is actually incredibly similar to the patient I dealt with in Liverpool who went into type 1 respiratory failure. And this time though, because the ECMO services had expanded after the 2009 pandemic, we were able to transfer her to the Royal Brompton. In fact, they had to come to her. She was so sick. They actually brought their machinery. They actually came and they put her on ECMO actually on the unit. What was interesting is that of the doctors dealing with her in the unit, I was the only person who was actually up to date with my flu vaccination. So everybody else then had to be contact tested, and it was a real mess. And I've got this lovely picture to show you how I didn't actually use any proper PPE. And I feel that, so I should have done, because I was supposed to be booked in to have the PPE testing, but I couldn't be bothered, I thought, I don't need this kind of stuff. It doesn't really matter that much to me. And so actually, none of us handling the influenza patients on delivery suites or ITU or theatres actually used proper PPE. But that's quite, but none of us actually came to any harm from it. So it's very interesting. So then the UK government, having seen the effects of the swine flu pandemic, they then carried out a thing called Operation Cygnus. And as you probably know, Cygnus is the word for a swan. So they thought, well, if we had an H1N1 pandemic, what if we got an even nastier form of influenza? Let's call it swan flu. And let's examine how we would manage this from a central government point of view. What kind of things would we put in place? What's our command and control? What happens if the NHS is completely overwhelmed? And then they started to delve into details. So how many acute medical beds do we need? How many ITU beds? Where's our PPE? We're going to need a lot of gowns, a lot of masks, a lot of gloves. Do we have all that in place? Do we have enough ITU ventilators? So they carried out this exercise, and the conclusion was, well, no, we don't. We're not really ready for it. But they thought, well, do you know what? We've got away with this for years, because at the end of the day, the last big pandemic that had a huge problem was 1918. So, let's just, okay, it's a problem. We recognize the problem. The chief medical officer raised some concerns, and they just buried the report. And in fact, the report wasn't actually published until somebody put in a Freedom of Information request in April 2020. So, yeah, although we have a national health service and we got a lot of advantages that this, in theory, it's a well-organized system with very good sort of central controls, but I think it was pretty well recognized that the NHS wasn't really going to cope well in the event of a future pandemic. And I thought, everybody thought, well, let's just hope we get lucky here. Let's hope that life's not that bad. And then along comes COVID. And whether it's the fault of the pangolin or not, or whether it's the bats, or whether it's anything else, but we saw this happening, and there were some very learned doctors in the UK who thought, well, do you know what? Look, it's another Far Eastern flu thing. It's just another one of those SARS or MERS. They've never reached us in the past. There was the outbreak in Toronto we knew about, but it will be a confined thing. It won't be that bad. Even though they're building 1,000-bed hospitals overnight and in a week's time, and there were all kinds of stuff happening, it looks pretty scary. We thought, well, it'll be okay. And then it reached Italy in February. And in West Middlesex, we've got quite a few Italian consultants. In my department at the time, we had 2 consultantistas from Italy, one who trains, one who comes from Girona, the other who actually trained in Lombardy and knew all the Italian doctors who are actually directly involved. And we've actually just appointed another superb consultantistas from Italy as well, this time from Rome. So we do have a strong Italian connections at West Middlesex. And so these things were very real because these people on WhatsApp groups were their professors who are saying, this is horrific, this is Armageddon, we're being overwhelmed, our ITUs are beyond capacity, we're having to look after patients in very unhospital type conditions. This is going to come to you. So quite scary stuff. So we then had the challenge of this wave was coming, this tsunami of patients were coming. How are we going to prepare for it? And we thought, well, London's likely to be first affected because, of course, we have so many international international sort of connections with London, very different from the rest of the UK. And of course, our population locally is also high risk as well. Our patients have a lot of comorbidities, a lot of prevalence of hypertension, diabetes, obesity, chronic obstructive airways disease, alcoholic liver disease, etc. And then also we thought, well, if it's like the flu pandemic, then it's probably going to affect pregnant women pretty badly. And we need to therefore protect our staff and our patients alike, particularly as this thing seems to be spreading like wildfire, unlike the flu things. And so our staff were very anxious. And one of my main challenges, I think, as clinical director was to try and actually calm people down, because we were trying to have planning meetings and they would turn more into therapy sessions, I'd say, really trying to just get people to actually calm down and relax. And the fact that we're doctors, this is our job. We have to treat patients with infectious diseases. And then we have to work out how we're going to coordinate critical illness. And obviously, pregnancy is particularly important because it's different. If someone is reaching an end of life scenario, let's say someone's 90 years old and they pitch up with respiratory failure with COVID, well, it's a pretty reasonable thing to do, to say, we're not going to particularly treat you, we're going to just sort of give you some fairly conservative therapy. But pregnant women, well, that's really important. We have to stop. And then we also have to work out how we're going to run our service with staff sickness, because we have to anticipate that as well. And then we know just even things like, well, how do patients get to hospital? Because if the ambulances are busy ferrying patients back and forth with COVID, then what happens if a pregnant woman needs an ambulance? You might call an ambulance, but one may not come. Again, people attending A&E, if a pregnant woman attends A&E, well, again, there may be a whole queue of people in A&E if they're overwhelmed, if they develop medical problems, how to deal with that. And of course, obviously, most importantly of all, we used to ITU being wonderful to pregnant patients. Normally they'd always give our pregnant patients first priority. But if they're literally spilled, if they're working at double, even triple capacity, how are we going to treat them? So we had this challenge of preparing for things, and we got into full preparation mode, and we made use of information coming from China, and then more up to date, more sort of westernized information coming from Italy. So when did it break? Well, as you can see, on the 9th of March, we started to get our first trickle of cases in London, and we're on this sort of western side of London over here. So you can see a few dots, and then literally within a couple of weeks, we're then gone from 61 cases to 2,500 cases. And as you can see from the graph on the right, you can see that the top line is London. So London's was so far ahead of the UK, and we took a very large and very early hit. So the biggest challenge was that we had huge amounts of information coming out as to what to do. And what we need to do is get people to understand things, because we had to change their practice. So you couldn't just do what you normally did for patients. We had to then work in a way that actually protected us from our patients, because we normally work to protect the patients from us. So when an obstetric anaesthetist puts an epidural or spinal in, the reason why they wear their hat and gloves is to stop transmission of our bugs to our patients. But now we've got the reverse risk. And of course, the problem is also, and it's doubly important to protect the staff, because obviously if the staff then become infected at work, then they could then transmit that infection to other patients. So we don't want our staff to be vectors. So we've got a whole new terminology, and it took quite some time to actually get this sorted out. But the Obstetric Anaesthetist Association did this wonderful job that they sat down and they created simple infographics, and they distributed them by a special WhatsApp group. So a set of group for all the lead obstetric anaesthetists throughout the UK. And that way we could get sort of real-time information, and it was very useful. And so you had a chance to literally speak to the authors of these things. So there's something that you didn't quite understand, you just ping and say, I know you say this, but I don't quite understand it. Or in our trust, they want us to do something else instead. And so the infographics was incredibly helpful. So it actually defines what we mean by PPE. And in fact, we tend to now use the term standard PPE and full PPE, because AGP PPE is a bit of a mouthful, really. So, and of course the sterile PPE, well, that's what we normally use anyway when we just do a simple neuraxial block. And obviously the choice of PPE depends on what we're trying to protect ourselves for, whether it's an aerosol, whether it's droplets, whether it's contact with body fluids. And at the time, the key risk was thought to be intubation and extubation. So therefore, we were taking particular concern about the process of induction of general anaesthesia and extubation from general anaesthesia. Those were the high-risk procedures that we particularly focused upon. And whereas straightforward neuraxial blockade, and one of the advantages that we have as anaesthetists is that we get to work on the patient's back. So even if the patient's coughing and spluttering, well, at least they're doing that away from us, which we felt would be quite helpful. So we defined what we meant by PPE. So then it was felt that during labour epidural analgesia, there was no increased aerosolization risk. So therefore, we would be at the same risk as the midwife who is in the room looking after the patient. And similarly, if somebody was having an elective cesarean section, well, again, we should be able to use the same sterile PPE that we would to do their spine or combined spinal epidural. But if there's an emergency procedure, well, that's tricky, because we know that the conversion rate to general anaesthesia can be significant. So in the typical audit figures we work upon will be less than 1% for electives, but maybe up to 5% for emergencies. So therefore, you have to risk assess, and you need to think that bit more carefully. So one of the things that people then started to do was actually, so for example, in some units, what they decided was, if there was an epidural in labour, well, why not just do a spinal? Because the spinal was more reliable than an epidural top-up. Actually, I'd found at West Middlesex, most of our epidurals actually worked pretty well. So our GA conversion rate from epidurals that work on labour is pretty good. But then we're using a solution, the fast mix solution, that again is associated with a very good success rate of top-up. But then, of course, we come to the highest risk of all, then, which is general anaesthesia. And obviously, what we're going to try and do is actually minimize the risk of general anesthesia for cesarean delivery. So, because we know we've got to do an awful lot of stuff. So what we've got to do, if it's not just a case of there's no time, there's severe fetal distress, we've got to take this patient to theatre, get them off to sleep as soon as possible, that time element is now going to have a new factor, which is we're going to rush and take this patient to theatre, but then we have to carefully don our protective equipment. and we cannot do anything until we've actually donned our equipment safely. And then ideally, we would also really want to restrict the number of people in the theatre to a bare minimum, because we don't really want everybody to actually have to be exposed to the aerosol. But so that, for example, might apply to somebody with, let's say, a cesarean section under general anaesthesia, which is under GA because of, let's say, concerns about coagulopathy, or because you can't physically put a regional block in. But if it's a time critical situation, so let's say severe fetal distress, concerns about hypoxic ischemic encephalopathy, then in that situation, the anaesthetist, the ODP, the scrub team, the obstetricians are all going to have to actually gown up together. But that, of course, is quite a faff. And actually, when you actually work out how long that takes, then it might actually be quicker to actually do a quick spinal. So,
Phil, so you have 3 more minutes, Phil, if you don't mind.
How many?
3 more minutes.
Oh, 3 more minutes. Okay, I shall go through. Okay, so yes, so we worked out a process of donning. We worked out a checklist, and that's very important because we tried this in practice and we made loads of mistakes in practice. So we kept rehearsing until we got it just right. We then set aside a room for that way we could put all the challenging cases, all the COVID patients in a converted side room instead, to try and keep them away. One of the challenges was, well, okay, we got the anaesthetic machine there, which is lovely, but what happens to the gas from the anaesthetic machine? Where does that go? And I then remembered what was in the old journals of anaesthesia, a thing called an aldosorber. So I managed to get hold of some of these aldosorber cartridges, and we then plumbed those in, and that then stopped everybody going to sleep when patients had a general anaesthetic. Now, so in terms of staffing, we had our standard staffing in terms of our registrar level covering delivery suite, our senior registrar levels who then helped. And then as consultants, anaesthetists, we then had to become resident. And this was the view that we had of the ITU, which had all this temporary plastic sheeting and 4x2s put up. And this was where we worked, helping our ITU colleagues, intubating our patients on ITU, and also being there to deal with obstetric emergencies. Whilst we were doing all this, of course, our Prime Minister was very busy writing new policies and protocols, and looking at the rising rate of COVID, as you can see. And of course, we had to cope with PPE shortage, which is why it's so important to try and ration it appropriately. So that way, for the epidurals, just use droplet protection, and then FFP3s for the airborne. But it took a long time to try and convince everybody that's what we needed to do. We needed a COVID-safe intubation technique. And one of the things that was very clear was that our obstetric registrars, who spent, well, mainly clinical fellows in obstetrics, who barely did any intubations each year, they'd never used a glide scope. So we got everybody good at using glide scopes. And that was very helpful. At West Middlesex, we did a lot of work with major hemorrhage and coagulation. And we know with COVID-19 patients, you can see major change in coagulation. They can either become hypercoagulable or they can have coagulopathies. And we found Rotem very helpful in managing patients with coagulation changes.
Oh dear, I have to stop you there.
Oh, please do.
Thank you very much for this lovely presentation. I would love to listen to you for another hour because we don't have time.
No problems at all. No problems. Very happy.
Very nice presentation, full of lovely practical information, really. And it tells you that even in UK, we can make mistakes, you know? It is trial and error, is all a learning curve for people at home, so that don't get disheartened if things go wrong. This is part of the game. So if you can stop sharing, Philip, now, so that, yeah, if you can just go to the stop sharing knob.
I shall do the stop sharing thing here.
Yeah, and then I know that Dr. Majid Al-Khatib is already here, our president. I would love to ask him just to give a welcome. He had a problem in joining in because of the link, and I hope this is not a general problem. Please, Dr. Al-Khatib, a platform for you for a couple of minutes. Yeah, thank you.
Thank you very much, Ali, and many thanks for Philip for his nice presentation, although I joined a bit late. And I would like to extend in my thanks to all the speakers who are giving up their valuable time on Saturday evening. I know how precious, whether they are in UK or elsewhere. And this is part of our series of that's organized by Ali, patient safety, which proved to be very, very useful. And we are ever so grateful for you for helping our patients and doctors in order to improve our practice and our colleagues' practice in Iraq, and to share knowledge and information and practice with them. I wish you all the best. Thank you. I'm not going to take time at all, and I'm not going to name every single body, but thank you all, and thank you, Ali, for the...
Thank you, Majid. We're glad to have you with us. We're honored to have you. Now we come into the next speaker, Dora. I got her biography. She's a Greek lady, wonderful Greek lady. Her full name is Theodora Kostolopoulou. She's trained and certified in anesthesia and intensive care medicine in Greece. And she's also had her PhD in anesthesia at the National and Kapodistrias University of Athens, Greece. She has completed a fellowship in ITU medicine in Imperial College, and she is one of the ITU consultant anesthetists in our West Middlesex Hospital. We're very glad and honored to have her here. Dora, the platform is for you.
Welcome.
Thank you. Thank you all. It's a pleasure to be with you tonight. And it's always a pleasure to share a glimpse of my world in intensive care. So today, I'm going to go through a literature review and present some of the challenges that we face in intensive care when you admit pregnant ladies with COVID. So let me see if I can share my screen.
Yes, start sharing.
I hope it is okay. Yep.
Yeah, we can see it, Dora. You can talk.
Perfect. So critical care, I think, is the last place an expectant or a new mom could ever imagine she will end up. And while we do see obstetric patients in intensive care, they're not so common. But when they come, they're by far the most complicated group of patients that we might admit. In this presentation, I will say a couple of words about the epidemiology of COVID pregnancy in intensive care. I will focus mostly on the respiratory support in intensive care because this is why they're admitted in the first place. And a couple of things about the management of COVID-19 in critically ill obstetric patients as per guidelines. I will discuss about the timing of delivery, which is a subject that really is trending, and I will tell about complications, outcomes, and then the key points. So going through the literature, I found out that while the overall risk of critical illness is low, COVID infection is associated with more severe disease in pregnant versus non-pregnant ladies. And there is an increased risk of poor obstetric outcomes, for example, preterm birth. The pregnant women have been found to have significant higher rates of ICU admission, mechanical ventilation, going on ECMO, death, and there is an increased risk for severe disease in the group of 35 to 44 years old, which are more likely to be mechanically ventilated and more likely to die comparing to non-pregnant women of the same age. There was a systematic review where they described the maternal factors which are associated with severe disease, and these are the increased maternal age, high BMI, any pre-existing comorbidities, preeclampsia, and women from Black, Asian, minority ethnic origin. There is also an observational cohort study which found that there is a higher incidence of adverse perinatal outcomes like C-section or hypertensive disorders of pregnancy in women with severe disease versus the same group with asymptomatic patients from COVID. And there's a higher risk of preterm birth and stillbirth at any time in this group of people. A couple of words about how pregnancy changes the physiology in the woman. So the respiratory and immune system adapts to pregnancy, which is normal. And this might explain in part why these women have severe disease. The chest wall compliance is decreased because of the changes of pregnancy. The FRC is decreased, and there is also the diaphragmatic splitting from the enlarging uterus. The hormonal and the immunoregularity changes that happen might influence the immune system as well. And during pregnancy, the blood volume increases, so there is increased afterload, blood returning to the heart, and preload, and there is also vasodilatation, which decreases the afterload. This is the amount of pressure that the heart needs to inject the blood during the ventricular contraction. And this woman has also got peripheral vascular resistance, which is decreased, which is that mediated by the progesterone and the nitric oxide, which relax the vascular smooth muscle. So regarding the respiratory support in intensive care, just 2 words about the airway. We know that the airway is difficult in pregnant women because of the edema, the hyperemia. I told you already about the thoracic cage changes because due to the enlarging uterus and the hormonal effects with a decreased FRC up to 25% by term. Even so, the lung compliance is not altered, but because the chest wall compliance is altered, the total respiratory compliance is reduced. And that makes ventilation challenging. We have increased minute ventilation in pregnant women, up to 40% above baseline, that's normal, and they have mild respiratory alkalosis and compensatory renal exertion of bicarbonate in their arterial blood gases. The airway management, as I said, is challenging. The failed intubation is more common in pregnant women anyway. And because of the decreased FRC and increased oxygen consumption, they don't have enough oxygen reserve, which results in rapid desaturation in response to apnea or hypoventilation. This could be challenging when we need to intubate someone in intensive care with COVID pneumonitis, which are already struggling. And of course, we have the delayed gastric emptying, which is the case in women and pregnant women, and decreased intra-abdominal pressure. For women who are admitted in intensive care, COVID or non-COVID, the ARDS is the leading cause of maternal death in intensive care. The causes of ARDS are many: pneumonia, sepsis, obstetric-related causes. There are some thoughts that maybe the maternal hypoxemia and hypercapnia might be harmful for the fetus, but there's not enough data for that. But we do know that the blood gas exchange from the fetal to is not only through the maternal blood gases, but also from, it depends on the perfusion of the placenta. And that's why we have to be aware of how the uterine blood flow impacts oxygen delivery to the fetus, and take care of the blood pressure as well. The respiratory support in intensive care, I'm saying some targets here, but again, because with a lot of a lot of numbers of women who are in RCTs, these are mostly based on physiology and expert opinion. So we're aiming for SATs above 94, 95, and oxygen targets of PO2 of 9 to 10 kilopascal. There are not enough data of what is normally good to keep the PCO2 while intubated. But it's not clear whether the permissive hypercapnia, which is a quite common practice in people in ARDS, non-pregnant people with ARDS in ICU, is well tolerated by the fetus. The non-invasive mechanical ventilation can be an option, but according to the literature that I have reviewed, there are some risks, and those risks are associated with the aspiration, which is due to decreased gastric emptying, decreased intra-abdominal pressure, and a decreased esophageal sphincter tone. It is more successful in cases where the NIV would be short-term, and what we can reverse quite quickly, for example, pulmonary edema. And there is also a report from with 186 women from the influenza era, which described that 83 of them who received NIV, they have avoided the intubation in 38, which is 46%, and it is quite good. But the NIV failure was associated with septic shock as a cause and high severity of illness. So it is doable, and I have seen women managed on NIV and finally with COVID and avoiding intubation, but it should be for long term. And here we go to the invasive mechanical ventilation. Again, the evidence-based data are limited because pregnant women are not excluded or not important as a subgroup in the mechanical ventilation trials. So as I said, the recommendations are based on physiological concepts, small observation studies, and expert opinion. Keeping in mind the major physiological changes in pregnancy, which I have explained earlier, the reduced chest wall compliance, the increased minute ventilation, the respiratory alkalosis, I made this table where in the first column we see what the parameters, the second one, the pregnant women, and the third column, the non-pregnant. So regarding the position of the lady in the bed, we would like them to have the left lateral position. And sorry? Head elevation to minimize reflux. In the non-pregnant patients, we have always the head of bed elevation to limit the incidence of VAP. The tidal volumes, they're not enough data, but 6 ml per kilo predicted body weight is quite sensible target, and there's no difference in the non-pregnant women. We can tolerate higher plateau pressure on the ventilator because of the chest wall compliance. So if in non-pregnant patients, we say up to 30, but in pregnant, we can be a little bit more higher, like 35. Regarding the PEEP, we have to be aware that there will be basal atelectasis due to the elevated diaphragm. The SATs go, as I said, 94, 95 and above in pregnant women. In non-pregnant, we can accept lower. But again, this 94, 95 is just a number. They're not the evidence-based data to say that. Regarding the carbon dioxide, in pregnant women, we say that hypochremia could be harmful, but there's not enough data on hypercapnia. They say that moderate levels may be safe, while in non-pregnant population, we do accept permissive hypercapnia in ARDS. As for rescue interventions with neuromuscular blockade, prone positioning, and extracorporeal life support like ECMO, there's no change apart from the long-term neuromuscular blockade is not really well studied for pregnant ladies, and it's better to have intermittent rather than continuous. There are some small studies which they say that the APRV, airway pressure release ventilation, as a mode of ventilation, could be potentially beneficial for this population because it provides non-ventilation which doesn't cause injury to the lungs and can achieve optimal lung volumes. Prone positioning in pregnancy, it is doable. There are studies that describe prone positioning, and there's also a prospective study which shows that indeed can relieve the uterine compression of the adult's maternal vessels and improve the placental blood flow. It can be considered, and if it is clinically indicated, to help with the maternal ventilation, and it can be done safely and effectively, at least until the early third trimester. There are cases with pregnant ladies with COVID who had ECMO with a good outcome.
You have 3 more minutes, Dora.
Oh, okay, I'll run. And from the flu pandemic, the survival rate from ECMO was 75%. So I'm just say a couple of words about the medication or the management that we use. We use oxygen, we use prednisolone, we use tocilizumab as well. We have to be aware that if we give it after the 20 weeks of gestation, the baby shouldn't have live vaccine after they're 6 months old. Remdesivir can be given, but it's not like a norm. VT prophylaxis is in the guidelines, and pregnant women should have VT prophylaxis. And the new one, the monoclonal antibodies, can be considered in pregnant people with COVID, especially in those with additional risk factors. The timing of delivery is a huge question. There are studies that they say it might help, but it mostly helps, just to sum up, when the cause of the ARDS is obstetric. It should be individualized, and it has to be assessed in cases, in every case separately. Complications that we see is preeclampsia, HLH syndrome, which is real, but it can be done and triggered by the COVID infection. Hematologic changes, as mentioned, it could be either hypercoagulopathy or hypo. And it's also some incidence of cardiomyopathy post-COVID. So the outcome, there is 90% mortality after mechanical ventilation of women of ARDS. All neonates survived. Some of them required mechanical ventilation. Some of them, 20% demonstrated neurological impairment at 6 months. The long-term outcomes, so they're not data available again, but there is weakness, myopathy, neuropathy, which are treated from the very long intensive care stay, physiological distress, PTSD, anxiety, panic attacks, and even cognitive impairment. And there's always problem with the patient and family communication. If they can visit, time to bond with the baby. Key point is that we need a multidisciplinary approach. Chest X-ray scan should not be withheld in pregnancy. They can be done at any time if they add something to the clinical management. Thromboprophylaxis is a must. And management should include monitoring of the baby and the uterus, individualized delivery planning. And the thing that I really want to stress is that we don't have a lot of data about this population. So trials just exclude pregnant women and lactating women. So we do not have a lot of evidence-based recommendation, and this limits our treatment options. So I would say that when possible, it will be wise to include pregnant and lactating women and should not be excluded from the clinical trials just because they're pregnant. And that's it.
Well done. You managed on time. Thank you, Dora. Very nice of you. Very lovely presentation. If you just stop sharing now, so that we can go on with our meeting. So the next speaker is our local Iraqi specialist, Associate Professor, Dr. Walid Al-Ansari. Dr. Walid Al-Ansari, he has a long biography here. I can read you some of the interesting things in it. He's a faculty member in the Mother College of Medicine in Iraq. He has 24-year experience in critical care in the best medical center in Iraq, which is the Medical City. And also he's instructor supervisor an Iraqi and Arabic board for anesthesia intensive care medicine. So he's just the right man for this presentation and this talk. I can read you something more. His main interest is a critical care medicine and medical education, teaching, supervision, examining undergraduate student in clinical service. He started his ICU career coming from an anesthetic background, giving him the confidence needed in dealing with the critical cases. We are very lucky to have him today, Dr. Walid Al-Ansari. Please, Dr. Walid, if you start sharing your presentation.
Just like to second your welcome to him because I know Walid very well. Thank you very much, Walid, for joining us and for giving up your time and for agreeing to speak to us tonight. Thank you. And he's a good friend.
Good evening, everybody. Good evening, Dr. Majid. Good evening, Dr. Ali. I think, Dr. Ali, you remember we have been met before in Babylon Hotel when you came with Dr. Muhammad Ramadan. And we asked you to present a talk about the use of spinal anesthesia for cesarean because the obstetrician were reluctant to accept this concept. But you are, so I would like to say to you that now spinal anesthesia is a routine and everybody in every hospital do that on daily basis. Spinal anesthesia for obstetric.
Thank you, Walid. I remember that was 2009.
Yes,
in
exactly.
Rashid Hotel, 2000. Imagine, time flies. Thank you very much for reminding me, and thank you very much for the progress in regional anesthesia in Iraq. Brilliant. Please carry on.
Okay. Okay. I'm sharing my presentation.
Yeah.
Good. It's coming. Yeah.
Okay. Okay.
And thank you, Dora, for your lovely presentation, by the way. Thank you.
Okay. Good evening, everybody. Again, oxygen therapy, you know, every home now in Iraq contain many cylinders or an oxygen generator. So everybody using oxygen in his home because there is, you know, the condition in the health system in Iraq. Well, okay. The objectives from this talk that by the end of this couple of slides, the attendee will know something about the effects and causes of hypoxia, how to use oxygen delivery devices and the indications of each one of them, and how to prescribe oxygen, and finally drawbacks of oxygen therapy. Well, first of all, we will speak about the effect of hypoxia, the hypoxic patient. How can I know that my patient is hypoxic? We will see that my patient is cyanotic, tachycardic, tachypnic, and in addition to that, we will have CNS manifestations such as confusion, dizziness, irritability, agitation, and sometimes nausea and vomiting. But simply we can put the sensor on the finger on the bulb of the ear if it's a pediatric age group. The sensor will tell us that the saturation, how much the saturation he has. So we have targets for that number. So the aim for us is 94 to 98 in most of patients, but in COPD or type 2 respiratory failure, we will accept less than that, about 88 to 92%. So always we shouldn't exceed the target. Well, let us talk about the causes of hypoxemia. We have 5 main causes of hypoxemia: the low PiO2, hypoventilation, ventilation perfusion mismatch, right to left shunting, and diffusional impairment. But in fact, we haven't seen the first one and the last one, because high PiO2 it's occur only when we have a patient in the high altitude. And again, diffusional impairment, we have seen them mainly when we use second gas effects, especially when you have nitrous oxide in the use. So mainly the main three causes will be hypoventilation, ventilation perfusion mismatch, and right to left shunting. And as far as we are in the COVID era, all of you have seen these types of CTs. As you know, Gattinoni explained the phenotypes of the lungs of COVID patients to two types: the phenotype L, which is in the left of the slide, and phenotype H. In phenotype L, we will see the ground glass opacities and the shunting fraction is very low, while in the phenotype H, we will have the bilateral pulmonary consolidation and the shunting fraction will be very high. But in addition with that, we may see that there will be some micro and macro thrombosis and filling defects, especially in the mediastinal windows when we have them in our CTs. In addition to that, we have in our patients, we may ask ourselves why these changes occur, especially in COVID patients. In COVID patients, because the virus will occupy the ACE2 receptor, there will be a dysregulation of pulmonary vasculature and pulmonary vasoplasia, which will lead to abolishing pulmonary hypoxic vasoconstriction, and finally lead to VQ mismatch, low VQ. But while in phenotype H, which is in the right side of the slide, when the alveoli being flooded with the fluid and there will be mucosal thickening, there will be abolishing of hypoxic pulmonary vasoconstriction and will be alveolar problem and AR picture similar to ARDS, and the shunting will increase, which will lead to further VQ mismatch. In addition to that, when we have a micro or macro thrombosis, which will lead to increasing the problem of the mismatch. Well, in addition to that, we may notice that we have patients comfortable in his bed with a saturation less than 90. So what's called happy hypoxia or the silent hypoxia. In fact, we should understand why this occurs and we shouldn't neglect this problem. Firstly, all of you know from the physiology that we have the oxygen flux. The oxygen flux is the amount of oxygen delivered from left ventricle each minute, and it will depend mainly on the cardiac output multiplied by the content of the blood of the oxygen in the blood, which is the oxygen bound and the dissolved oxygen. And because the dissolved oxygen will be very low, you know, from physiological background, mainly if you take the most important factors of this equation, it will be depend on cardiac output, hemoglobin, and oxygen saturation. This multiplying these factors will give us 1,000 milliliter of oxygen per minute. While in fact, so we have an oxygen flux of 1,000 milliliter per minute coming from our left ventricle, supplying the tissues. In fact, we are in need of only 250 to 300. So if our patient have a good cardiac output and good hemoglobin, in spite that he has low oxygen saturation, will have this number, I mean 250 or 300. So our patient is comfortable, because this process done with couple of days, multiple days, and the patient has been adapted during this prolonged period for this amount of oxygen. But this problem should be treated, and we should deal properly with this, because he is compensating, and when he is going to lose this compensation, our patient may collapse. So the next question is, what are the devices that I have to improve oxygenation? Simply, we have nasal cannula, simple face mask with or without venturi, non-breathing reservoir bag, high flow nasal cannula, ventilatory support, and ECMO. And I'll speak about the first four, because you know ventilatory support and its strategies and the use of ECMO need maybe long time to speak about. So I concentrate on that because every home in Iraq now using these instruments, and maybe they use them wrongly. Well, starting from nasal cannula, this is the photo of it. It is just a nasal approach attached to a tubing system, and this tubing system can be connected to a cylinder or in a wall-mounted place. So we can use them with a flow of 2 to 6 liters per minute, and it gives approximately 24 to 50% of IO2. So we should know from that each liter used for nasal cannula, each liter of oxygen will add to the FiO2 4%. So as we know, as you know, that from the room air we have 20% oxygen. So each liter will add 4. So when we have 1 liter, so it will be 24% of FiO2. 2 liters to 28, and so on. I'll clarify that by tables. So the indication of using nasal cannula is low to moderate oxygen requirement, and the advantage that it is easily tolerated and no breathing, and it is low cost. But it has a disadvantage that it's easily dislodged and the mouth not covered. The second one is the simple face mask. This is a photo of the simple face mask. It can be used mostly with Venturi, but even can be used without, and sometimes. Simple face mask indication is that when you need low to moderate oxygen requirements, the flow rate can be used 5 to 10 liters per minute, and the oxygen delivery is variable. It depends mainly on the attached piece of the Venturi. So we have an open port to exhale the gas, and the air entered through the inlet port. And as I said, it will deliver 35 to 55 if you give 5 to 10 liters. While in nasal cannula, there is no benefit from giving more than 6 liters of oxygen. The Venturi is its indication that when we have a specific moderate oxygen requirement, example in COPD, the flow rate can be adapted specifically for the adapter that we are using during our session, and the oxygen delivery will be 24 to 60 depending on the adapter that we are using. So these are samples of them. They are with multiple colors, and each color is marked with the percent of the oxygen that can be delivered through it, and you see the difference between the pores, that these pores will help to entrain the gas from the room air to dilute the amount of gas driven to the patient. The third one is the partial rebreather and non-rebreather reservoir mask. Well, we will have an oxygen directed into the reservoir bag, and during inspiration, the patient will draw from the bag and from the pores present in the mask. It can deliver up to 60%. Well, while when we put a one-way valve, which is the non-breathing mask, when we put a valve, the first valve, which is this one will prevent the exhalation, the exhaled air go through the bag, and the second valve will prevent the air coming from the exterior of the environment. So we can deliver up to 80 plus, up to 100% oxygen if we give the proper flow rate. The flow rate will be about 12 to 15 liters per minute. It's indication that when we need high oxygen requirement, and as I said, it can deliver 80 plus, maybe reach 100% oxygen. The last instrument that we will talk about is the high flow nasal cannula. It has been used widely in COVID-19. It is available with many names such as the OptiFlow, and the preset parameters, we have 2+1. We have the flow rate, which is 5 to 60 liters per minute, and the FiO2, which is maybe 21 to 100%. The third one, as I said, 2+1, is we should heat and humidify the air which is used during our management, because if we neglect this point, the patient will deliver dryness of the mucosa, and this dryness will lead to epistaxis. It can be used to treat the the hypoxemic respiratory failure, not hypercapnic respiratory failure. And the monitoring is very essential because sometimes it gives us a false negative result when our patient is conscious, but he is deteriorating regarding this respiratory status. So we have a rule of thumb when we are using it, with that when we have 60-60, I mean 60 flow rate with a 60 FiO2, we should convert him to the non-invasive ventilation. These are, I think they are useful tables. I put them in my unit. The nasal cannula, the oxygen mask, the mask with reservoir, and the relation between the flow rate and the FiO2. So as I said before, as far as we have 20% from the room air, when we use 1 liter, it will be 24, 2 liters will be 28, and so on. While when using oxygen mask, we have 5 to 6 liters, will deliver 40%. And mask with reservoir, we may reach 80 plus. So when we have 15 liters, we will have maybe 100% oxygen. We should always have a plan, and our plan in using oxygen in critical care situation, that we should ask ourselves 2 questions before we proceed. The first question, that is our patient is critically ill or in a pre-arrest condition. If yes, which is commence treating him with reservoir mask or back valve mask. If no, we should ask ourselves the next question, the second, that is my patient is type 2 respiratory failure, I mean hypercapnic or not. If yes, our target will be 88. If no, our target will be 94. And we should continue our story by the other details regarding the patient.
Dr. Walid, you have 3 moments, please.
Okay, I'm almost finished. Well, the last question, which may ask ourselves, why oxygen might be harmful? It is a very beneficial thing. Yes, but we have, 3 main problems. The absorption atelectasis, which is, imagine when our alveoli is this room, and as you know, the room air contain 79% nitrogen. So when we have, it is 100% oxygen, all that amount will be absorbed, and we will end with alveolar collapse. While when we have the nitrogen, it will keep the alveoli open. So this what's called absorption atelectasis in summary. And in addition to that, the chemical effect, what's called chemical atelectasis, which is simply that the oxygen, as you know, if I give an oxygen more than the capability of the body, the antitoxins stores, antioxidant stores that present in our body, it will lead to liberation of free radicals, and these free radicals will have a lethal effect upon the pneumocyte 1 and 2, and especially pneumocyte 2, which is responsible of secretion of surfactant, which decreases surface tension and keep the alveoli open. So by using a high percent of oxygen, we are killing the pneumocyte 2, and we have a collapsed alveoli, and this will lead to chemical atelectasis. In addition to that, without the oxygen toxicity, which is retrolental fibroplegia in neonates and other than that. Well, the final thing, that environmental hazards. Everybody of you remember that what's done in Ibn al-Khatib hospital when a lady cooked something beside a cylinder of oxygen, and we should know that the presence of these cylinders without proper usage may lead to environmental hazards. Well, dealing with oxygen is just like dealing with any drug, so it should be prescribed properly. So using what kind of device and what percent of oxygen and the timing of that using. And the take-home messages from this presentation, that recognizing oxygen delivery device is very essential, as each one has its own indication and therapeutic flow rate. Happy hypoxia should be recognized and treated promptly. Drawbacks of oxygen therapy should be taken in regard in managing hypoxic patient. Oxygen therapy should be documented as far as prescribing any drug, because it is just like that. Thank you, and apology for if I delayed in my time.
No, you are perfect, on time. Dr. Walid, I'm so happy to see you today. In fact, you brought me back to more than 10 years ago.
Thank
Really,
you.
When
I'm
Dr.
happy too.
Majid, when Dr. Majid suggested your name, I didn't know it, you are the person, because I thought I lost you forever, because we met in that hotel more than 10 years ago.
Yes.
And you had big hopes for Iraq at the time, and you started at that time your ICU unit for the first time.
Exactly.
And I'm so happy to hear that all move forwards. Regional anesthesia now is a routine in Iraq, spinal, epidural, and all that. I'm so happy for that. Can you just stop sharing now so that we can move on?
Yes, okay.
So I'm coming now to the fourth speaker, in fact, Dr. Mukhaled Al-Ta'i. He's a local Iraqi anesthetist. He qualified in 2007 from Mustansiriya Medical School. He spent some time in Libya, went for 3 years, worked there, and then he came back in Iraq. And currently, he worked before in a cardiology center in Iraq, in which he was in Najaf particularly. He was doing the catheterization, responsible for the care there. And nowadays, he's working in a maternity place. So he's just the right man for today, because over the last 2 years, he was mainly involved with COVID cases in pregnancy. So I'm very glad to have him here. Dr. Mukhaled, can you share your talk, please, and have the platform? Dr. Mukhaled, do you hear me? Yeah, because I saw him earlier on, very earlier on. He came very early, but now it doesn't look he's around. So because we have a tight timetable, I suggest we go to the next item, to the cases. Manal, and then we can come back to Dr. Mukhaled talk. Manal, can you hear me, Manal?
Yes, I can hear you.
Manal, take over now to the cases, please, and organize it.
Is my voice now clear?
Yeah, we can hear you. We
can
hear you loud and clear. Yes.
Okay, good. During this pandemic, the last 3 months, June, July, and August, we have about 14 dead patients in Karbala. And this 14 dead patient was only in pregnant patients. And their age, about 30 years, I have patients, about 3/4 patients is there about their age 30, between 30 and 35. Other about 90, 95. Yes, all of them are young age patients, young pregnant. Their pregnancy ranging from the first trimester, second trimester, and those patients die within a few days inside the intensive care unit. We don't know what is the problem happened, in spite of all the effort done between the anesthetists and the obstetricians. They do a lot of effort in order to save these patients' life. But I discussed with Dr. Ali to make this webinar in order to find a way to save those patients, those young patients, and where is the defect, where is the problem, why they came too late, or there is another risk for these patients to make their suddenly they die even after we do a delivery for them. We trying to save their lives. Nothing got with this patient and improve their oxygen saturation, and they suddenly they pass away. So we have 2 cases today. One of them we have Dr. Khdair,
yeah,
and Dr. Shahed. Dr. Khdair, are you all now? Dr. Khdair? Okay, Dr. Shahed?
Yes.
Are you available? Dr. Khdair? Okay, start
Yes.
your case.
Hello, doctor.
Dr. Khwair, just share your presentation, please.
Okay, sir.
Take your time. Dr. Khwair, don't mention any names, not even the name of the hospital. Everything should be confidential. And we're just going to listen to you and obviously discuss the management at the end. Lamis, can you make him co-host, please, so he can share? Lamis?
Yep, sure.
Because otherwise he cannot share. Dr. Shahid as well. Yeah, Dr. Shahid, stay around because you're going to be after. Dr. Khwair, you have 10 minutes. You just give us a highlight of the presentation and start sharing, please.
Inshallah.
It's not allowing me to add him as a co-host.
Why is that? Because he's not handsome or something?
I think because I left accidentally, so I think you've become the host now. So
Yeah, Khwair,
Yes.
can you share now? If you cannot, then Shahid, what about you, Shahid? One of you have to start. Really, we have limited time. We cannot waste the minutes. Lamis, make Shahid as well as a co-host.
I think now you've become the host, Dr. Ali. So if you could just right-click the three dots near Shahid.
I can do that for them. Okay, let me just. So what do I need to click on that, on the thing, on the knob?
Yeah, the three dots, the blue dots.
Yeah, I'm doing that now. And let me just, so it's all my host. Okay, make co-host, yes. Sorry, this is my fault. You are co-host now, Khwair.
Yes.
Yeah, sure, darling. Yeah, thank you.
It's clear?
Yes.
Now?
Yeah, yeah. Put your slides. We can see something, but not the slide. And let me make Shahid as well co-host so that she can. Shahid, I made you co-host as well.
Thank you.
Khwair, I give you one more chance. If you cannot do it, then we move to Shahid.
Okay.
And then
دكتور خليل، خلي السكرين، خلي الباوربوينت or on the screen and then use share your screen. يعني افتحها المحاضرة الأول، افتحها المحاضرة وبعدين سوي شكرين. افتحها أول، هي تنعرض. نعم.
Okay. Yes, we got it. Yes, brilliant. Yeah. Okay.
Hello.
Yes.
Hello, everybody.
Hello.
Hello. It's my nice to present my case, which is in morning of Sunday of 25 of July 2021. When present a lady to our ICU, it was 35 years old, 8 months period, 32 weeks pregnant, obese lady. She was gravida 5, para 2, abortion 2. All his by cesarean section. She was complaining from shortness of breath, productive cough, increased body temperature for 5 days previously. She is also a non-case of gestational hypertension. She was on 200 milligram methyl dopa tablet, and she didn't receive coronavirus. When we examined her, she was conscious, opaque command. She was severe dyspneic and tachypneic, not cyanosis, but she was pale and sweaty and looked severely ill on wheelchair. Her vital sign was pulse rate 130 beat per minute and blood pressure 145 over 80 millimeter mercury, and her saturation was 60 on room air and temperature 38 CEZ. By auscultation, her chest showed a good air entry bilateral with fine crepitation. And she told us she have a poor fetal movement days ago. Her lab investigation was random blood sugar 90 gram per deciliter. Her hemoglobin was 10.3 gram per deciliter. Her white BC was 13,000, platelet 291, and lymphocyte was 100 neutrophil 0.3, and her blood urea was 17, and her serum creatinine 0.5 and calcium 8.5. ALT as liver function test was 17, AST was 27, and alkaline phosphate was 98. D-dimer was 78.9. Seroactive protein was 3, and she done PCR and was positive. Her CT scan for chest show 60 to 70% pulmonary involvement. Infiltration and abdominal ultrasound show normal single vital fetus, cephalic presentation, and FL it was 32 weeks and 3 days, not brevia, and lower normal limited amount of clear liquid. Immediately when we present her, when we see her, we give her oxygen therapy by non-rebreathing bath with a flow more than 15 ml per minute, and her saturation improved to reach 85%, but still have tachypnea. Respiratory rate was about 45 breath per minute. Blood gases show her pH was 7.130, PaO2 was 70 millimeters, and PaCO2 was 22 millimeters mercury, and bicarbon was 60 to 26 millimole, and her lactate 2.3. She admitted to our ICU for 4 days. Meanwhile, this 4 days, she was on non-invasive mechanical ventilation as CPAP with FiO2 100%, and PEEP was 6, and pressure support 8 above PEEP. And she received remdesivir vial for 8 days because she was taking at home for 4 days and 4 days in ICU. So total was 8 days, and she was on mironibinine vial as broad spectrum antibiotic, 1 gram every 8 hours, and on enoxaparin 6,000 international unit every 12 hours as prophylactic for thromboembolism, and paracetamol as analgesia 1 gram every 8 hours, and umbrazole vial as GIT protection 14 milligram every 24 hours, and acetylcysteine tablet 600 milligram every 8 hours, and she is on dextrose saline 1000 cc every 24 hours. So in 82 of July at 12 p.m., she developed vaginal bleeding and abdominal contraction. So the decision was to start termination of her pregnancy. She was preferred to refer her to operation room as emergency cesarean section. Resident doctor prepared her for 2 pints of blood, 2 pints of plasma, 1 platelet, and check vital sign. He was blood pressure 110, and pulse rate was 120, and saturation about 80. Transfers by ambulance patient with portable CPAP on same يعني FiO2 100 and PEEP10, and I was in operating room when I was in call for emergency. I received patient at 3 a.m. Excuse me, about 3 p.m. Immediately I put for her 2 large for cannula, green 18's gauge in her hand, and
you get better before you start work. You started on Monday, so you still have tomorrow. So if tomorrow you feel better, then on Monday you will feel so much better.
Salam, please mute yourself. Salam, we're hearing you. Or we are, carry on, dear.
Okay. Immediately I prepare patient with 2 large, as I said, cannula, and I give her fluid with as normal saline, 500 cc. And in sitting position, I prepare for spinal anesthesia, and I give her bovicaine 3 ml, about 50 milligram. Then patient placed in supine position, on still in portable ventilation with non-invasive on CPAP, and here cesarean done for her by gynecologist as lower segment transverse C section. Take time about 25 minutes, and after that baby is delivered, and baby resuscitated good. After that, the surgery finished. The total amount of fluid we give for her was 1,500 cc, and 15 cc of plasma, 35 cc of blood. I give her dexamethasone 8 milligram, gave her hydrocortisone 100 milligram, and I give her ketamine about 30 milligram, and ephedrine 5 milligram 3 times. And finally, her vital sign was 100 blood pressure 100/50, and heart rate was 105 beat per minute, and her random blood sugar was 150. But patient is still in dyspnea and tachypnea. Respiratory rate reach 40, and saturation become better, reach 90, and it was sleepy. Glasgow coma scales around 10. But unfortunately, after next morning of operation, I heard the patient is passed and baby still alive.
Thank you very much.
Know.
Yeah.
Thank you, sir.
Thank you. Can stop sharing now.
Okay.
And let me go to the panel, and maybe so that we still fresh in our mind what we've read. Please, Philip and Dora and Dr. Al-Ansari, please, if you, each one of you, if you can give your comments or question to Khadija so that we can have some clues,
Yeah, so can I start?
Yes, please, yes.
So I think I'd like to start at the end, because obviously I appreciate these are very challenging patients to deal with. She's come in, she's got established COVID pneumonia, she's hypoxic. At the end of the operation, the saturation was 90%, the hemoglobin was good. So at the end of the operation, you seem to be in a reasonably good place. But then after that, she died. So what level of monitoring did she have between you stopping looking after her and then you coming back the following day? Who was actually looking after her, and what's the level of nursing was she receiving?
So she returned to ICU, and there it was a resident doctor and student anesthetics. They take about care, and lady become better at night, but suddenly after at night of this day, patient become deterioration in Glasgow, also in saturation, and at morning it's passed.
Okay, so I would have So in the UK, I'd have thought that if somebody's, so did you have any arterial monitoring to measure her, to take blood gases?
After operation,
did you have an arterial line in?
Yes, not have arterial line.
She didn't. Yeah.
She didn't.
She didn't have arterial line. Yes.
Okay, so I think that's, again, obviously I don't know what facilities you have available. But obviously for me, if somebody's in an intensive care unit,
it's not available in our ICU.
It's not available. Oh,
it's not available. No, it's not available in our ICU.
Wow.
So you cannot do arterial line in ICU. Where do you do the arterial line then?
We don't have arterial line in ICU. Only we have puncture for ABG.
Yeah, it's very difficult because I think this is the kind of patients who would have benefited hugely from an arterial line, because so what I think may have happened here is that I think there may be a degree of pulmonary overload. So how much blood did she lose during her cesarean section?
Do
you know from the operation notes? How much blood loss?
About 500 cc lost from her cesarean.
So not a lot.
So
section, yes.
Yeah, because what's happened is that you've actually given her quite a lot of fluid. You've actually given her the liter of Hartmann's, and you gave her a blood transfusion and plasma as well. And I think it's possible. And then there's quite a lot of fluid shifts, quite a lot of auto transfusion that happens at the time of the cesarean section, particularly when the blood loss is quite low. So I'm used to dealing with this Professor Nakash. His patients lose very little blood during their operations, and so we very rarely give people blood transfusions. And I think, and again, and this is where Dora will sort of pitch in as well. But I think that patients with COVID pneumonitis and who are pregnant will be very sensitive to any fluid shifts. And I think it'd be quite easy to tip into pulmonary edema. And obviously that's then quite, so if you've got an arterial line and you can do gases, I think you can pick these things up. But I think I have seen pregnant women sort of just literally just flash into pulmonary edema, and it's very hard to pick that up on top of the odds of the COVID pneumonia as well. But again, this is where I also like Laura's inputs. But I just wonder whether there's a degree of fluid overload as well, actually. But just, for me, it's just it'd be so difficult for me managing a patient like this without sort of having these sort of full ICU facilities that I'd come to expect.
Yeah, the thing I don't understand, arterial line is not rocket science when you are an ITU anesthetist. Why should not an ITU lady have an arterial line? So why you are in ITU anyway if you don't have an arterial line?
Excuse me?
Yes. The arterial line. Are you trained as anesthetist to do arterial line?
Yes. I am training to do central veins and arterial lines in our ICU, but in monitor we don't have the arterial monitoring.
Yeah, but in these kind of patients, these are critical COVID patients, you just understood what Dr. Barkley said.
Yes.
This is a COVID lady, pregnant COVID lady. The physiology is quite different. After she delivers, it's very easy to push her into pulmonary edema. It's very easy. Thinking you give it her fluid and you're not measuring input, output and all that. So you're pushing her into pulmonary edema very easily. And then after that, you don't monitor her. So in the monitoring in the ICU, what do you do? Just blood pressure and pulse? Because this is not an ITU if it's only pulse and blood pressure. What monitoring do you do in ICU?
In our ICU, the monitoring only saturation and blood pressure and pulse rate and heart rate, ECG, and monitoring for ventilator machine. Okay. We don't have arterial line monitoring because our machine is our monitoring is not available.
So leave that. So how do
Yes.
you make sure you don't overload patient, post-operative patient? How do you make sure you don't over-infuse them? What do you do?
By measuring the input and output.
So what was the input and output for this patient? Do you have that?
Input was around 2000 cc from blood and plasma and fluid.
So
And her urine,
she had 2 liters. 2 liters.
2
Okay.
liters, yes.
So
And 1 liter is out.
What
1
is the
liter
out?
is as urine.
What
1
is
liter.
What is the output? 1 liter.
1 liter.
Yeah. So there is 1 whole liter
And
inside.
and 500 cc about bleeding from her surgery by suction and gauze.
I think we understood the message in this. Philip made it very clearly, and then we can go. Philip, can you stop sharing, because now we're seeing your desktop so that we can go to the. I think you start sharing with us accidentally. Your desktop.
That is not Philip, it's Group X.
Who is a Group X? Can you stop that, please?
Sorry, Dr. Ali, can I say something?
Yeah, you can say something, please. Yeah.
Okay. Well, Dr. Thayyab, well, you don't have an arterial line, but you at least you may, from your clinical monitoring and from using the echocardiography or ultrasonography, you can decide whether your patient is overloaded or not. So do you use the ultrasonography or echocardiography in your
No, sir. No, sir. No, sir.
Okay, by this webinar, I would like to advertise that every doctor, every trainee would like to know how to use the ultrasonography or echocardiography in the ICU. He can come to our unit, and by the way, we made more than 441 training course about this, but never mind, I can accept any request from you if you would like in your unit to do that.
Inshallah.
Please,
Shukran.
thank you, Dr. Wali. Thank you for that. Dora, do you have anything to add? Yeah, please.
I appreciate that the monitoring is different in different places of world. The facilities are different. In this case, I would like to stress that this woman had a lot of risk factors. She was obese. She had pre-existing comorbidities like hypertension, as you mentioned. She comes after some days of COVID, so she's very hypoxic. And of course, the lack of some monitoring like an arterial blood gases. I have only the admission one, which was acidotic. The other thing I want to stress, you can always do an ultrasound, check the fluid status. You can do a chest X-ray when she deteriorates further. I mean, you can say that, you can check the lungs, you can examine her. And the other thing is, I agree with Dr. Barclay, it could be the shift of fluids that happened after the C-section. Furosemide is always an option when our patient deteriorates respiratory. So we try to get them at least some furosemide to get them negative fluid balance. That might help with respiratory function. So for me.
You see, it's the care. Yeah, the nurse was there. Probably she was checking her blood pressure and pulse and oxygen saturation the whole night. But the lady still died because there's probably no doctor listening to her chest just to see the crackles and the pulmonary edema signs. And the easiest thing to use is giving her furosemide, the one we used to use in Iraq, 1 ampoule, 40 milligram. This make her diurese in 1 minute, 2 liters. So essentially these simple things, basic things, you don't need to have a high-tech ICU equipment for that. You just need really basic clinical monitoring, proper clinical monitoring, not simply checking her blood pressure and oxygen saturation. really. This is the most important lesson really for you. Dr. Walid Al-Ansari, thankfully, he suggested that he train you really for at least doing arterial line. But the arterial line is not the only thing which could have saved her life. The proper monitoring is not simply really, please, you have to stress on the staff, on the doctors, staying overnight, so to do their really job properly, yeah? Because we lost life completely unnecessary. Thank you for your presentation. We go
Thank
down.
you.
We go down to Shahad, please.
Good evening, everyone.
Good evening, Shahad. You can share your document, darling.
Yeah. Here, I'd like to share my case. Actually, it's one of many of the cases that we are confronting every day in our ICU. Especially over the past few months, we have noticed a spike increase in the number of pregnant women severely infected with COVID, especially with the appearance of Delta variant, and the low rate of vaccine take-up among the expectant mothers, because many people here, they are just hearing the rumors about the vaccine, so they prefer not to take up the vaccine, especially the pregnant women. Here we present a case of 27 years old, pregnant. She's in her third trimester, 31 weeks plus 3 days. She has para-1, and she has a history of 3 abortions before. She delivered normally before, normal vaginal delivery. Her BMI is elevated, it's above 30, but she has no other comorbidities associated. She presented to hospital with history of 5 days high-grade fever, myalgia, dry cough. So I think that she was presenting late because she was very, very technical when she was presenting for SARS-CoV-2. So we just admitted her directly to ICU because gene therapy in sequence. We just admitted her directly to the ICU. On admission, the patient was conscious, alert, but she looks exhausted, distressed, and extremely tachypneic. Oxygen saturation was 70 to 80% on room air, swinging between these two ranges. Her vitals, respiratory rate 35, pulse rate tachycardia 129, blood pressure 116/71, temperature 38.4 degrees Celsius. And here are her laboratory investigations. It shows that the hemoglobin platelets are within normal, white BC 13,000, which is usually normal in pregnant women because most of them are presented with leukocytosis. And this is the problem that we face with pregnant women. All of them, they come late. Many of the pregnant women, we are misdiagnosing them as preeclampsia. Because we have we notice there is a similarity in the systemic clinical manifestations between preeclampsia and COVID patients. Here we have lymphocytopenia in this case. The D-dimer was also elevated. All the inflammatory markers are elevated too. And the LDH is highly elevated. Her ABG, it is within normal range, but it likes to be shifted towards hypocapnia and hypoxia. Of course, the radiological imaging, they confirm that there are patchy consolidation in both lung fields. The CT scan also show that 60 to 70% of both lungs are involved with a ground glass appearance infiltrates. As Dr. Khair mentioned, the treatment regimen for ICU COVID patient is the oxygen therapy. We start directly with antiviral therapy. Analgesia, we use paracetamol only. We don't use non-steroidal or anything. Thromboprophylaxis, especially the pregnant women, are in a hypercoagulable state. And this lady, she has highly elevated D-dimer. Imprazole, steroids, broad spectrum antibiotics as a coverage. We use it routinely, and N-acetylcysteine as a nebulizer to encourage mucus and help them to expel the mucus. So we started immediately with non-invasive positive pressure ventilation. We think that we don't have time to start the simple auto mask or the normal breathing mask. So we started with non-invasive positive pressure directly. We started with a low fraction of inspired oxygen, about 0.6, and then we increment gradually. We were planning to decrease the work of breathing, but unfortunately we couldn't reach this level. And the saturation began to, at first it improved to 85, around 90, but it didn't reach the optimal level that we are looking for, about 94%. So, and the patient was really tachypnic. After 12 hours of ineffective, non-invasive pressure ventilation with high fraction of inspired oxygen, we discussed the decision of intubation with the family, but unfortunately the family refused to sign a consent because there is a widespread belief here that during this pandemic, the invasive ventilation is associated with very high risk to the mother and to the baby. So most of the patients, they refuse to get intubated. They prefer to stay on non-invasive. They prefer that they see their patients without sedation, that they are communicating with them during the visits. So they refuse to sign the consent. And then we have a collaboration to decide about whether to terminate the pregnancy. There was a multidisciplinary team who discussed about the mortality rate of this critically ill mother and the fate of her baby. The decision went for termination of pregnancy. The family were preferring the cesarean section, but actually we find that there is no strong indication for cesarean section, and especially she has delivered normally before and she has 3 miscarriages before, so there is no strong indication for cesarean section, no obstetrical indication. The only indication for termination of pregnancy is that she is in severe and critical pneumonia. The patient, we kept her on during that period. We have a hypercapnic while monitoring her ABG. So we shifted from CPAP to bi-level in order to make a washout for the CO2 with high inspired oxygen and labor-induced using a very small dose of misoprostol, 25 microgram. We use only 1 dose, and then the mother, she has lower uterine contractions, and the trial had succeeded, and a baby girl weighing 2.2 kilograms delivered normally, but her Apgar score was 7. We transferred her immediately to the NICU. Meanwhile, after delivery, we were expecting that the mother will be improved. But actually, it was astonishing for us that she is deteriorating. She was in the same state of respiratory distress, ongoing respiratory failure, according to her ABG readings. The patient was in severe RDS, PF ratio was below 150, poor compliant lung, according to the ventilatory parameters. And as you see the ABG parameters, we see that she has hypoxemia, hypocapnia, and the lactates level also increasing, the D-dimer also increasing. The clinical picture started to worsen gradually. So, and after a few hours, all this happened in a very, very short period of time. She went into an altered mental state. We intubated her directly, and we started the invasive ventilation, vasopressor. We used vasopressor through a central line to keep her hemodynamically stable. Unfortunately, here we don't have facilities for ECMO therapy for such a critical case, and we lose the patient within hours. Thank you.
Okay, thank you, Shahad. Thank you.
Thank you so much. Thank you.
So I leave it to Philip and Dora, please. Yeah, Philip, if you want to. Yeah, you can stop sharing now.
So one of the,
I will.
So one of the challenges for me with allowing somebody to labor. So as you say, the choice here is we want to deliver the baby because the baby is viable, and also to actually allow the baby to continue in that situation will be bad for the baby as well. So you've made the decision to deliver, but then to labor could also be challenging for somebody who's hypoxic. As you say, you have to step up the level of ventilation. Was it an option to use an epidural to actually to decrease the work of breathing during labor?
To decrease the work of breathing during labor?
Yeah.
Actually, the labor didn't take that much long hours. All of it was less than in 3 hours. 3 to yeah.
But nevertheless, it's still if she's very basically she's struggling to breathe when she's doing nothing.
Of course, yeah.
But then so and exhaustion I think will have been a factor. One of the reasons why I'm sure you wanted to intubate her so much earlier was because you could see how exhausted she was when she arrived.
Yeah.
And obviously if the family had agreed to do that, then that would have been a far easier therapeutic option because your hands are tied, you know, they haven't consented, so you can't do that. So and that's then quite tricky because then you put the workload of a labor, and I appreciate it's a short labor, 3 hours is quite short, but then running a marathon is
I know
hours.
it's a burden on the cardiopulmonary
it's still
system. I know that,
and it could account perhaps for why so I was thinking that maybe some of it is the additional exhaustion of her respiratory system through laboring.
Yeah.
And then you've got the fluid shifts as well that also occur again, and there tends to be decreased blood loss associated with a vaginal delivery.
Yeah.
And do you have active management of the third stage as well? Did you give her?
Sorry.
Did you give her oxytocics?
Yeah.
No. We didn't give any. It's only the misoprostol tocolytic.
Shahad, you are the anesthetist. You are not the obstetrician. So probably let Manal talk about her delivery because probably you don't know about the delivery bit. Manal, are you around? Manal.
Yes, I'm here, but I didn't know.
Manal, what happened in her delivery? She's para 2, allowed to labor normally without analgesia probably. And who made that decision? Was it the consultant who decided let her deliver normally? Who decided that?
This lady, I don't know, have any information about her and about her delivery. I think Dr. Shahad was on call on that day. I don't know what happened.
Are you anesthetist or obstetrician?
I'm the anesthetist.
Yeah, exactly. But you cannot comment on obstetric things.
On call on that day, I don't know anything about.
Actually, sorry, it was not my decision. It was the decision of the obstetrician to deliver her normally.
This is what I'm saying. This is the decision of the obstetrician. When they decide to let a lady with a critical COVID to have natural birth, they should have enough logic for that. This is a lady, how many liters of oxygen she was in during labor? How many liters, do you know?
Yeah, she was on 100% oxygen.
5%.
100% oxygen.
100% oxygen.
Yeah,
100% oxygen. Poor lady. She'd been laboring for 3 hours.
Yeah.
I know cesarean section in Iraq is very high. Why, for example, they didn't take her for cesarean section? I don't understand.
Yeah. She's a preterm.
How many weeks she is?
31 week. 31 week plus 3 days.
This is even more reason for that. You know, these cases we have here in the UK, they all have cesarean section. Once they get intubated, they have cesarean section. I know your hands were tied. Yeah. If the family said, no, don't intubate her. But again, as an obstetrician, you can make the load and the stress less on her by quickening her delivery, not giving her 3 hours or maybe more of strenuous labor, painful labor and pushing and all that. This has aggravated her respiratory work, is it, Philip? What do you think?
I think this lady started labor normally and not induction of labor.
But she had misoprostol.
Normal labor, spontaneous labor.
Oh, yeah, I thought you said she had misoprostol to induce labor.
Yeah, it was not.
You induce her. No,
her labor was induced.
No, Manal, she was induced. Really, the obstetrician here, the one who's responsible, he has to be justifying his management. She wasn't spontaneous. She had misoprostol. She wasn't spontaneous. She's 31 weeks. If she is 39 weeks, coming 4 centimeters dilated, you might think, let's just break her water. She popped her baby in 2 hours. But this is 31 week critical COVID coming in critical, and you inducing her and you're hoping she push it in the 3 hours. You were lucky she pushed it in 3 hours, but she lost her life. She lost her life. This is the obstetrician has to be asked and justify his decision about it. This is all confidential between us here. I don't know what you think, Dora, about it.
2 things. This woman comes late with COVID symptoms. Her procalcitonin is 130, which shows that there must be an infection on top of the COVID pneumonitis at this point. So we have a woman with mixed presentation of sepsis and COVID pneumonitis. I understand the communication might be difficult with the families. We have the same issue here in the UK. When I call them and ask people and tell the families that I want to intubate, the first reaction is, oh, they're gonna die, because they feel that if we come to this point, they will die. But this woman was very bad, and she eventually died. And I think the family should be aware that if we don't tube now, she will definitely die. What I have done differently, I will tube her straight away, take the baby, and then prone her. Maybe that might help her a bit. We do that, we've done that with a lady who's more far in her pregnancy, 38 weeks here. She had a long admission, but she finally made it.
Yeah,
you don't have to have the ECMO. You just have to do, pronic might help with those people, but you have to take control of the breathing, not an IV. At this point, intubation, take the baby and prone.
You should put it clearly to the patient, Manan, please. In these cases, or to the anesthetist, you tell the family, if we don't do the tube, she would die. Your daughter would die. I don't think any father or mother, if they hear this, they still say, no intubation, because they allowed it at the end, but that was too late. If you be so strong in your message to the patient, you don't go and talk like sitting on the fence. No, you say to her very clearly, Mom, Dad, your daughter would lose her life if we don't intubate her now, because we want to rest her lung. We want to make her preserve her oxygen and exertion. This is the only way we can give her a chance for living. So if you use such a strong message, not come like, oh yes, Mekhalif, all right, it's fine, don't worry, we won't intubate her. Because at the end of the day, you are responsible as well. You are responsible, not the obstetrician alone. You are as well responsible.
Sorry, doctor,
I'm not saying you. I am saying the team as a whole. I'm not saying you're responsible. I'm saying the anesthetist who's talking to the patient is the way he sells the information to the patient, to the parents, very important. The way you talk to the parents here, very important. We have difficult patients in UK all the time. Phillips knows about it, Dora knows about it. What do? We talk to them, we negotiate with them, and most of the time they come around. We don't just give up and do whatever they want us to do, because that's our duty, really. That's the whole thing. The message here to you, to transfer it to your team, that when we discuss this case, yeah, we appreciate the parents' wishes and all that, but the counseling to the parents was not satisfactory. And the evidence, they resigned to intubation, but it was too late. She died. This is the whole thing. This is the whole thing. And the issue of the delivery, Manal, you have really to take this on board. Preterm ladies, severe critical COVID, get intubated and have cesarean section. Nobody in UK go and venture and induce them. Really, because you don't know how many hours it's going to take. You can be for sure 100%, because if you do, you just play lottery with the life of the patient. You just gamble with the life of the patient. So that's the message to you, the obstetrician. What do you think, Philip? Do you have anything else?
Well, the only thing is as you say, we have very difficult patients in the UK as well. I mean, we've got a patient who Dominica saw, who is refusing to come to the hospital because she says that everybody in the hospital has been vaccinated, and that if she has any contact with people who are vaccinated, then she's going to have, then the vaccine's going to enter her body, and that's going to cause her problems. And so she signed a special waiver to say that we can't possibly give her any blood, because the blood probably comes from somebody who's been vaccinated. And she's insisting upon having a home birth. And Dominica's gone through everything to try and reassure her about the safety. And this is a simple situation. This is somebody who's completely well, but who's just is so irrational by this process. So I've got a huge sympathy for your position as an anaesthetist dealing with somebody who's hypoxic, because you're offering a treatment, but then the only time you're actually able to deliver it is in a peri-arrest scenario, by which time the mortality is so high that, you know, you're literally, you know, you've got very little chance of success. So actually I've got a huge sympathy with you, because unfortunately people have the opportunity that I think maybe in the UK, the families have less influence perhaps in the UK over consent. It tends to mainly be if the patient will agree, then we can.
Yeah, if the patient says no, and with his team to have capacity, we first talk to the patient and second with the family.
Yeah,
that's important, Shahad. She was awake, she was conscious.
Yeah.
So did you ask her?
So different.
Ask her about
intubation. About intubation, because
actually I didn't ask her. I asked her husband, her father and mother. That's all who I asked.
No, the patient you should really ask
because
first.
They mentioned that they have witnessed many patients who have been early intubated and they get the same results, and that's why they refused.
I mean, Dora,
I think also the consent system in Iraq is different.
Yeah, it is, sure.
Okay, yeah, thank you very much, really. That was very helpful, really. And I think Mukhaled is here now. Dr. Mukhaled, sorry, you are supposed to, the fourth speaker, is he here, please? No, he's not here. Yeah, still not here. So now I leave it to Islam to run the question and answers. Islam, please, carry on.
Hi, everyone. Thank you very much all for your presentation. It's been really helpful and really informative. Thank you very much. Regarding questions in the chat, I didn't really get much questions. The only thing they were talking about the last case, that is, they're basically just talking about the care for the patient in the last case, which I think the problem in Iraq is the way they take consent is different. In the UK, we usually ask consent only from the patient. The family is not even there. In Iraq, is different. You have to take consent from the family before the patient. So I think there are so many differences in the practices between the UK and Iraq. But that's the only thing that I got in the chat. The only other thing, maybe about intubation. So when exactly would early intubation be beneficial for pregnant women, especially women who have COVID-19 and they're pregnant? That's probably the only question.
That's to you, Philip, if you want, yeah.
So for me, what I'd ideally like to have done would have been to have actually admitted this woman, well, both the cases we to ITU for some optimization to try and try and optimally ventilate her, to try and increase, so the first patient had major acid-base problems. This patient, I think the main problem was exhaustion. And so at least that way, because there wasn't any urgent need to deliver the baby. There was no particular issues of fetal distress or anything like that. So I think we probably could have actually optimized her condition on ITU, and then came to that decision as to what progress she's actually making, and then you can decide whether you're going to deliver, and to hopefully do so having optimized her condition. And particularly, as Dora says, if there's a degree of sepsis going on there as well, if the procalcitonin indicates sepsis, then you've got a chance to actually control the sepsis. The antibiotics will have a chance to kick in as well, and then she'll be in a far better position at the time when she delivers. As you say, if she's intubated and ventilated, then the only option is a cesarean section. But that's a relatively straightforward thing to deal with. And then she then stays intubated and hopefully continues to get better on the unit afterwards. And that's something that we've done quite a few times in our ICU with reasonable success rates.
What about you,
Thank you
Dora?
very much.
Sorry, Dora. Let Dora.
Thanks. From what I have seen going through the literature, delivery of the baby doesn't always help with the mother. So in that case, and for her respiratory distress, for everyone, NIV, a short-term or NIV, it's a reasonable and sensible choice to start with. But it has to be under monitoring. You have to monitor blood gases, you have to monitor the rest rate, how they respond. A threshold when to intubate on an IV. Personally, I wouldn't wait for her to go on 100% on an IV, because then it is too late. The reserves, they're so little, and they can't really tolerate at all. And the intubation could be very, very risky at this point. My personal, and from my colleagues in intensive care, it would be a threshold of 80% NIV and not tolerating breaks at all of NIV. That's a reasonable, I believe, and sensible threshold to say, we're failing on NIV, we have to go and intubate now. Another thing is the communication with the family. I come from Greece as well, so I know the culture there. Families are very much involved in the care, much more than they are here in the UK. For me, I try to be open to anyone, to the patient, if they can understand they have capacity, because with hypoxemia, things might be a little bit difficult. And I try to be as open and honest to the family, stating the facts. When we come to the point that I need to proceed to more invasive ventilation and to more things, I just say it as simple as that. It's either this or they will die. And I say I should do this.
Absolutely.
Thank you, Dora.
Dr. Ali.
Thank you very much.
Dr. Ali.
Yes.
Sorry, I would like to say that for both cases, the intubation was late. I totally agree with Dora and with Philip that both of them, if you look to the lactate, both of them more than 2. If you look to the PaO2, both of them is about 50, which is very low. By the way, in the pregnant ladies, it should be not less than 70 because you have a baby. So for both of them, the intubation was very late. And should be started from the first day. They were, both of them, very exhausted, and especially the second case put it in such a disastrous situation when they deliver a normal vaginal delivery. So I totally agree and that with them, but the intubation was very late. And this story may be repeated with most of the patients. So for that reason, they lost that much number of the pregnant ladies. And in addition to that, when I'm said that using the ultrasonography and echocardiography I didn't mean that only the use of them in cannulation. We use that for even for monitoring. So as you know, by using ultrasonography and the echo, you can have an idea about the preload, the afterload, even the contractility of the cardiac situation. So those patients may have other problems in regard of the heart. So what about the heart of them? Maybe micro and macro thrombosis. So there were multiple problems with those patients. What I'm saying is that proper monitoring is very essential in the ITU. You mentioned a point that if you have a doctor who is listening properly to the chest and listening to the crackles, we may not lose the first one and the second one too. I don't know what about why they don't use that, but I don't know. It is essential in the ICU.
Yeah, Dr.
Yes.
Walid, for you as being man on the ground there and a good
Yes.
center where you have facilities. So you, the consultant, you go home, sleep at home, and then there would be the junior resident who stays
Yes.
overnight.
Yes.
The story in UK is different. There is a consultant probably overnight in
Yes.
the ITU. I don't know whether, do we have consultant overnight in the ITU?
There wasn't the search, but now we just cover and we stay as long as we need to stay.
Okay, so
I
essentially,
could stay overnight if needed.
yeah, well, the junior doctor, you require him to do Doppler and to do echo and all that during the night or 2 in the morning. Realistically, how realistic is that? Yes, during the
Yep.
daytime when the consultant is there, I
Yes.
agree with you. But during the 2 in the morning, 3 in the morning, it's kind of a dream. It's not going to happen really. I think what you need to concentrate in the training for these resident in anesthesia, ITU, anesthetist, whatever, registrar, or even junior, is that they use their clinical bedside skills.
Exactly. Exactly.
And
exactly.
important. Really,
Exactly.
because these are more important than the echo and the ultrasound and all these fancy things, which are probably
Exactly.
yeah. This is the
Yes.
thing. Second,
Sure.
I ask you, I beg you to make a recommendation to all your colleague anesthetists in Iraq, and I know how enthusiastic and keen you are because I met you before and I saw you, and you deliver the stuff when you want it. They should teach people about intubation, about
Yes.
counseling parents for intubation. They should tell parents very clearly the message that if we don't intubate now, your daughter would die. This strong message can change attitude, can change culture, because at the end of the day, nobody wants their little daughter to die. If you're going to tell her, look, if I don't put the tube in, your daughter would die in 1 hour. or 2 hours, they would do it. They would do it because they listen. This is a strong message.
Yes,
but if
exactly.
the anesthetist is coming like, so 50-50, coming like that, that wouldn't happen. So please make it in your guidelines, in your training workshop you do. And I know you have many of them and you have so many contacts all over Iraq, because these are cases which we're losing for really silly things. You know, this is the thing, for things which could have done much better, and we kept these young lives. So what do you think?
So can you give me a number, Dr. Ali? What do you think the number of the percent of death in intubated patient in COVID?
I take it to Dora. She probably know better than me.
No. I mean in Iraq. What do you think
Iraq,
the percent?
Okay. Yes. So what is the number?
Do you imagine that we have 100% death rate in intubated COVID patients?
100%.
Yes.
Really?
So for that reason, because almost always we are begging them to make the intubation early, but nobody do that.
No.
So you think they all leave it too late?
Yes, exactly. If you take these two cases, both of them, their saturation is around 60-70, which is what I'm saying about silent hypoxic, and they are with 60-70% involvement, and nobody intubate them. So why do we think they don't intubate them?
Is it the parents or what is it?
No, It is a general idea. Now you have an anesthetist in this webinar and ask them, do they intubate their patients with COVID early? No, nobody.
Really?
Nobody convinced with that idea.
So why not? Why not teach it?
This is a major problem. We have said that many times that we should do early intubation, not early intubation, but you have a criteria for intubation. And as I said, if we have 60, I mean, when you have just like what said from Dora, if you have more than 60% of IO2 for such a prolonged period, so how do you don't end with fibrosis and lung damage? So, but most of them stay for more than 20 or maybe months without intubation for such a high of IO2, and end with death.
End up with death.
Yes.
So what is the answer for that? What do you think we should do?
Really, I don't know, because I made many sessions, many webinars, many talks about this, and we put our guidelines. But most of the personnel who work in the ITU, they prefer, as far as their patient is conscious, and this is what I'm saying in my presentation, that sometimes we may be cheated by the good saturation, and while the patient is deteriorating.
So I had a chat, which is very clever. They say, ask the doctor, who is caring for the intubated patient in Iraq? Do you have, when you intubate somebody, is anybody caring for that patient?
Should be the ITU.
Are you sure?
ITU, the ICU.
There would be nurses sitting there taking care of everything? Trained nurses?
There should be nurses, there should be doctors. We have, Dr. Ali, we don't have a problem with the personnel. Yeah, I mean, we have many doctors. We have many, you know, in Emirat, in Qatar, in Saudi, every person, every doctor, everyone who have a white coat caring for the patient. We don't have problem with the personnel.
Yeah, but we have a problem.
But do you think there is a problem with educating doctors about the benefits of early intubation, about the risks of leaving them with NIV until, you know, they're...
Exactly.
I think educating doctors is very important. I think these webinars are very beneficial.
Exactly. They didn't convince by that. By the way, we said that many times. We said that many times. You know, one of the webinars with Germany from Heilbronn hospitals, they said that they left during the first wave. They have 0 death from intubated COVID patients because they left their patient on NIV only 2 hours. If they didn't improve, they intubate them and putting them prone. So ask the personnel who is in Iraq, how many anesthetists may make a prone position in the ITU? Nobody. Why?
Because lazy? Because they're lazy, they don't want to do it?
Because it needs a certain skill, you know, and they don't. I think they don't believe in that. We should ask them. If anybody has an answer, please, if there is anyone in the webinar and can convince us why they don't do proning.
You know, in UK, where they in our hospital, at least when I remember, because with the proning you need manpower, so they used to ask for volunteers from other departments and doctors to come and do it, because the ITU staff, there are limited number of trained people, and they cannot just go and keep doing a proning. So Dr. this is one of the clever things is done.
Dr. Ali, we have Dr. Ali, we have 2 years from the starting of COVID. You know يعني أنا ما بدي أحكي بالإنجليزي. أنت تدري أكو ناس عطالة بالعراق كوما. يعني دكتور علي ترى هذا موضوع البيرسونال، ترى يعني البيرسونال كوما عندنا. نقدر نجيب personnel من يعني.
He is not, as you said, is not the lack of
sorry,
the
this
staff.
is shameful to say. This is shameful to say. So I told you in a, يعني, you know, I mean what I'm saying is, by the way, Dr. Asin is in the chat, in the webinar now with us. She's one of our fellows. By the way, we made we established a fellowship in the ICU, and I'm in my unit now. I have fellows who following up the patients, fellowship of 2 years after the board, starting since 2016. So the ITU, is growing, but some doctors don't do the principles well, and I wouldn't like to mention some points in this webinars.
No.
And also, for example, the second case, the patient had sepsis, as Dr. Christodoulopoulos said. The patient had sepsis on top of that.
Yes,
so I
exactly.
think this needs to be managed clinically, at least, like sepsis 6, antibiotics, chest X-ray, all these things.
So just before we end this webinar, from Dr. Walid Ali, being the man on the ground, the consultant in Baghdad, please, can you update the guidelines for the anesthetists to force them, not to force them, just to tell them, stress the point about early intubation, 1. And 2, proper counseling for the parents. If the parents going to make the decision for the patient, let's just know how to talk to them. This is very important, really, because in these 2 cases, it could have made the difference between life and death. This is the thing. But anyway, thank you, everybody here.
There is another question.
Yeah.
That basically, Nas is saying that sometimes it's really difficult to put pregnant patients in a prone position.
It is, but it's doable. And of course, when they're awake and they're in an IV, they can always do self-positioning themselves. They don't have to be prone. They just have to lay lateral on the right or on the left side. This will help the lungs as well. And I said, because there are cases that you can prone safely and until the beginning of the first trimester. It's doable. It's like having someone who's got a big belly. You just put the pillows there. You just have to do their videos in the YouTube if you want to see how this is happening with pregnant ladies. It is doable. But even with that, just repositioning and don't let them on their back. Any changes in the body position can help with the lung recruitment. You don't have to put them fully on there, on the belly to achieve that.
Yes,
when they're on NIV, they can do that as well. That's what we say. We say that to the obese patients on NIV.
Thank you, Dora.
Yes. The rule, Dr. Ali, the rule, in COVID, because I would like to mention that because there are some obstetrician in the webinar. The rule in COVID that never let your patient with COVID lie supine. So even lateral, even simple bending is beneficial. So while most of our patients lying supine, and this will, affect the posterior aspect of the lung and to distract the lung early.
Dr. Walid, but we want to promise from you. We want to promise that this would change. Just talking about it wouldn't solve it.
Dr. Ali, I'm speaking about since 2 years, but and things in Iraq are different.
No.
I think Dr. Shahid.
No. The message has to go through. If you keep on saying it, it would get through. Whatever happened, you need to be more patient. You need to keep repeating it. And you remember what happened with the regional anesthesia, how Iraqis didn't believe 10 years ago in regional anesthesia.
Yes.
And how it happened now, how changed now, regional everywhere, epidural, spinal, the same thing. This is education. You need to have like what the British say, perseverance. You need persevere. You wouldn't need to just give up like just that. Nobody listened to me. I'm not going to do it again. I am hurt. Don't take it like that, please. You need keep saying it, keep repeating it, and tell them we lose patients. We lose patients that way. And we have statistics, as you just said it. 100% of intubated COVID patients in Iraq die, which is a shamble, a tragedy, whatever you want to call it. Anyway, thank you very much for coming today. Each one of you, please, speaker, you honored us and you helped us a lot, and definitely you helped the Iraqi patient. And we already 20 minutes late, so I have to put an end to the webinar. Bye for now. Bye, everybody. Thank you.
Thank you.
Thank you all. Thank you.
Thank you, Walid. Thank you,
Thank you.
Manal.
Thank you.
Thank you, Islam. Thank you, Shahad.
Thank you.
Thank you, darling.
Good night.
Bye-bye, dear.
Thank you.